Hello, I'm Brian Haug of the American Journal of Managed Care.
And I'm Sarah Stewart.
Welcome to This Week in Managed Care from the Managed Markets News Network. Our top story this week is from the Supreme Court, which kept intact the premium subsidies that allow 6 million Americans to afford coverage on healthcare.gov. In King v. Burwell, the court rejected the argument from plaintiffs that 6 words in the Affordable Care Act's legislation meant consumers in states without their own exchanges could not receive financial help to buy coverage. Most experts believe this is the last legal challenge that the law will face. This week, the American Society of Clinical Oncology released the first version of its framework for assessing value in cancer treatment options based on clinical benefit, side effects, and costs. The framework will help doctors work with patients to determine the value of new cancer therapies compared with existing treatments. ASCO developed the framework over the past year and applied it to 4 common cancer scenarios: metastatic lung cancer, advanced multiple myeloma, metastatic prostate cancer, and adjuvant therapy for HER2-positive breast cancer. ASCO now seeks input on the framework, which can be viewed at asco.org.
ASCO's initiative comes as many have complained that cancer drugs cost far too much. Now Dr. Peter Bach of Memorial Sloan Kettering has led the effort to show just how overpriced some drugs are. Dr. Bach and his colleagues have created an interactive calculator called Drug Abacus to price 50 cancer drugs based on their value. The calculator factors in side effects and how long they extend life. Dr. Bach found that some drugs were only worth a fraction of what is being charged.
This spring, Dr. Bach spoke to AJMC about the disconnect between what is happening in the realm of cancer research and in drug pricing.
Each year, when a cancer drug is introduced, what it delivers in terms of life years gained costs $8,500 more than a drug introduced the year before for the same health gain. In other words, we used to pay about $50,000, again in today's dollars, for drugs introduced in the 90s that gave a year of life, and now we pay 5 times that, about $250,000 for a year of life on average. In other words, and it's the only sector I can think of where new consumer products are becoming more expensive and incrementally less efficient. We pay more and more for each unit of health gain. And this is in the backdrop of a biomedical revolution, a complete change in the paradigm of drug development, targeted therapies, rapid approvals, much more sophisticated medicinal chemistry, immuno-oncology, lots of really exciting stuff, which should, like in every other sector, break the mold of innovation where we should finally be getting things that both work better and cost less. And instead, we're saying we have to pay more dollars for each health gain today than we ever have.
This week, researchers from Washington University reported in JAMA Internal Medicine that more than 2/3 of American adults over age 25 are overweight or obese, with a higher share being obese. The results are based on data from 2007 to 2012. While African Americans had the highest overall rates of obesity, every group has seen overall weight gain since 1994. Those over age 55 were more likely to be overweight or obese. The trend is a public health concern since obesity is the single biggest indicator of diabetes, which cost the nation $245 billion in medical care and lost productivity in 2012. The author said the nation needs a strategy to identify those at risk of weight gain itself, not just ways to screen for the diseases that obesity causes.
Coverage for therapies to fight obesity has challenged payers since there is not a clear consensus on who should be responsible. Dr. Jeffrey Dunn discussed this during a peer exchange hosted by the American Journal of Managed Care.
There should be a systematic approach to obesity management, just like there is for diabetes and other things. The problem is historically we've not had a lot of good options. And part of the problem is who's going to pay for this.
The $64 trillion question.
Yeah, so if you look at benefits, most obesity approaches are excluded benefits. Now, from a clinician, pharmacist that works for a payer, it's a major disconnect because we know the implications on other diseases and on outcomes. But the problem is you've got employers and other people who are looking at your insurance company for premiums. And if you're covering these drugs, the impact on the bottom line is huge. And so you're going to have negative adverse selection, and your premiums are going to be higher than somebody else. And so I agree that I think there needs to be a different approach to this, one of which is government, some kind of societal approach that evens the playing field so that we're not adversely impacted from a budget perspective.
Finally, the American Journal of Managed Care is proud to announce a partnership with the Patient Access Network Foundation. We are joining with the Foundation for the PAN Challenge, balancing moral hazard, affordability, and access to critical therapies in the age of cost sharing. This research competition will seek the best solutions to ensure access to cancer care in the era of unprecedented prices. To learn more, visit panfoundation.org.
For the Managed Market News Network, I'm Brian Haug.
And I'm Sarah Stewart.
Thanks for joining us.